So this is the first very important study which has actually changed the way we practice in metastatic HSPC. This has been a very important study for us. RASENS was, we know that is a blinded prospective pivotal study, which was actually designed to utilize the combination of ADT and docetaxel along with darolutamide in HSPC settings. We need to understand that tri-modality treatment has become one of the standard of care in patients with high risk, high disease burden. And the only thing which is holding back us for utilizing tri-modality treatment, especially with abiraterone and docetaxel combination, is the toxicity of the treatment. So we wanted to find some treatment which is at the same time effective but less toxic. So that is why RASENS is one of the most important trial which is available to us presently, because this trial included all the patients where we try to utilize trimodality treatment. At the same time, we want to give the benefit with less toxicity. So here, patients with performance status up to 1, patients of receiving who were candidate for ADT and docetaxel, they were stratified for extent of the disease, M1A versus B and C. Also, alkaline phosphatase high versus low. So these all are actually markers for disease burden. That is why they were used in the stratification purpose. And if we see, the patients were receiving darolutamide versus placebo in this study, along with docetaxel. 6 cycles of standard docetaxel were utilized. In the real practice, we sometimes utilize 2 weekly docetaxel as well. Primary endpoint of this study was overall survival. This is another very important point. This study is one of the less common studies where overall survival is one of the primary endpoint. So if we see the data, you can clearly see this is what, as a medical oncologist, we try to achieve a good improvement in the outcomes at the same time with less toxicity. So combination of darolutamide with ADT and docetaxel led to improvement in the median survivals, and median survival was not reached along as compared to 48 months. Another thing is what I wanted to highlight. This is a Western data mainly. Our patients do far poorly than this ADT plus docetaxel plus placebo, because we see a lot of patients who are progressing very rapidly after completion of docetaxel. We have seen even patients who are progressing even on docetaxel, though that is not very common, but that happens in the practice. We have now seen patients, because we are conducting another study where docetaxel plus abiraterone is being given. Abiraterone is given 2 doses, 250 versus 1000, fasting and fed state. In that trial also, we have found some patients progressing on the study itself. So it is not uncommon, but when you see quite a number of patients and follow up them well, you will understand and realize that yes, this is an important problem. We need to work on it and identify the patients who are doing far poor. And Indian patients are known to have PTEN mutation as well. Around 27% of Indian patients are known to have PTEN mutations. That is a marker of poor prognosis. At the same time, there is a concept called aggressive variant prostate cancer, which is very important and relevant for our setting, because a lot of our patients have P53 null type, and at the same time RB gene loss. So out of these 3 markers, even if 2 are present, these 3 can be easily done on IHC, P53, RB, and PTEN. If out of these 3, any 2 are lost, that means the disease is aggressive variant prostate cancer, and they will do far poorly than the routine patients. So we need to identify and characterize our patients very clearly. So this study is clearly suggestive that yes, if you are utilizing darolutamide in addition to docetaxel in upfront metastatic patients, de novo HSPC, you can see the difference hazard ratio is 0.71, and patients who are recurrent, who were M0 at initial diagnosis, but later turned out to be metastatic, became metastatic. Again, there is a benefit, hazard ratio is 0.61. In the routine practice, we get a lot of de novo metastatic patients, but however, with the improvement in the diagnostics workup and patients' awareness, I think we are now getting a lot of patients for non-metastatic as well. Also, NMCRPC, which we thought it is very rare, when we started to identify patients for the study purpose, because we have a phase 4 study of darolutamide, it became very important to us, our surprise, that we were getting continuously a significant number of patients who were NMCRPC that needed to be identified, which were not previously being stamped identified as an NMCRPC. We have recruited the highest number of patients for NMCRPC study throughout India. So this is the definition of high disease and high risk disease and volume disease. So again, we need to understand there are two concepts of volume and risk. So high volume disease, this I think everyone is very aware. Visceral metastasis, four or more bone metastasis with one beyond the vertebral column or pelvis. This we all know and understand. This is called high volume disease. But this is the charted criteria. At the same time, latitude criteria suggests about the risk of the disease, not the volume. The latitude criteria tells two or more risk factors with Gleason score of 8 or more, along with 3 or more bony metastasis or visceral metastasis. If 2 or more risk factors represent, it's a high risk disease. So both are important in their aspect, and volume and risk. We try to highlight both in our patients so that we can understand what is what. Only volume is not enough. Only risk stratification is also not enough. What we need is a combination of the two. If you see, visceral metastasis is common, number of bone metastasis is common, but Gleason is being incorporated in the high risk disease. So that is important. So if we see the high volume disease, you can clearly understand patients where darolutamide was utilized, the hazard ratio is 0.69. In low volume disease, if you see the number of the patient, the thing that I wanted to highlight here, if you can see on the screen, my cursor, that in the high volume disease, 497 versus 508 patients. While in the low volume disease, the percentage of patient is low, 154 and 146. That is why curves are not so different, but it is still hazard ratio 0.68. So that we need to understand and decide whether we want to add the third drug or not in such patient. In practice, we don't do, but yes, it is still possible on the basis of the trial data. But the individual physician can decide what he or she want to choose, and the patients accordingly. If we see again patients with high risk and low risk situation, so that is the other criteria which I discussed. The benefit is again very strong even in high risk and low risk. So low risk might not predict the non-benefit of darolutamide, but low volume is definitely somewhat different. So if low volume, you see the curves are nearly overlapping, though there is some statistical significant difference, but in low risk disease, the curves are still separated with a good hazard ratio of 0.62. So the message is clear. Always try to see the volume of the disease and also the risk of the disease. Risk becomes immaterial when we are deciding the tri-modality treatment, especially in this trial with darolutamide. So this is a very important thing for as a medical oncologist. Time to castration-resistant prostate cancer. We know that in castration resistance, patients tend to develop multiple new mutations and they are less likely to respond to the treatment. And whatever treatment we are providing, the patients will progress rapidly. So this example we get from Kumar sir, our mentor, routinely. Patients with docetaxel receiving in CRPC setting, the PFS is 6 to 8 months. While in HSPC setting, when you are giving docetaxel, PFS is 15 to 18 months. So it is tripling of the progression-free survivals. That is what we have learned from our mentors, and we continue to utilize these drugs wherever feasible in upfront setting. So utilize the drugs earlier when the patients are fit and you have most confidence of the utilizing the best possible treatment. So time to pain progression, these are also additional points showing benefit, which we know that if the drug is effective, the treatment will be effective in terms of multiple parameters. And also subsequent anti-neoplastic treatment can show the wide separation of the curve, which is well median with docetaxel alone with 25 months, and it was not reached. You can see the difference is very clear. So it's starting off next subsequent line of treatment with addition of darolutamide was significantly reduced. If you are adding darolutamide, and the patients are doing much better. So it seems that PSA response will be definitely better. And you can see the number of patients having undetectable PSA, because PSA level might not be so important for us as a physician, but the patient always has a very important psychological impact of seeing the PSA value at each visit. When we do PSA value, it is somewhat same as CA125 in ovary. Our patients are so much worried and they are fixed on the PSA value. If it was 0.2 at the last visit and it has become 0.3, they will become worried. So that is though not so important as a physician, but it has a psychological impact on the patients. So that is also important. Undetectable PSA levels at 24 weeks were attained in nearly 50% of the patients. So that is a importance. This is a similar benefit which we get from GnRH antagonist as well. The testosterone level becoming very low with GnRH antagonist, but here it has very significant psychological impact over patients. And at 52 weeks, you can understand 60% patients have undetectable PSA. Though I'm not highlighting that PSA levels are so important to have undetectable, but it has significant psychological impact of our patients. And it is very clear that patients who received this darolutamide treatment, the median duration of treatment was also significantly longer. And it was, you can see 16 months versus 41 months. So also, if you are adding darolutamide, the concern becomes whether you are able to complete chemotherapy or not, because what you think is that 6 cycles of docetaxel is the standard of care in HSPC, and the additional treatment is stopping the patient from completing 6 cycles of docetaxel. It will become a very big problem, which we are already facing with addition of the abiraterone. So in patients who are receiving docetaxel plus abiraterone, our 22% patients are unable to complete 6 cycles of complete docetaxel in our study, which is ongoing, and we have recruited close to 170 patients already in our randomized control trial. Here, the completion of 6 cycles in placebo arm was 85%, and it was 87% in darolutamide. So it's clear addition of darolutamide is not impacting the ability of the patients to complete 6 cycles of docetaxel. So that is very important and very consoling as a medical oncologist, that your additional treatment is not hampering the completion of the previous treatment, which is already the standard of the care. Let's see the adverse effects, which I was very highlighting from the beginning, fatigue and everything. We think the addition of the ARPIs will definitely lead to increase in some of the toxicities, and fatigue is one of them. But if you see the percentage of the patients having significant fatigue was not much different from placebo versus darolutamide addition. It was 22.9 and 33%. So similar. Other toxicities are somewhat similar. Only thing is somewhat increase in the rash, a small increase in hypertension, which are the class effect of the drug. The hypertension, you can, if you are utilizing darolutamide, abiraterone, or apalutamide, all these enzalutamide, all these drugs will have some increasement in the hypertension. That is very understandable, and you need to monitor it well. Now, we triplicate blood pressures in all our patients who are receiving these drugs. Patients get 3 times blood pressure measurement, and the mean value is taken in our OPD. So that is what we do in all patients, irrespective of patient is a part of trial or not. Triplicate blood pressure measurement is the standard of care at our center now. So that is very important. So now it is very clear that NMCRPC and HSPC has become the standard of the care. The only thing is the affordability. If you are able to utilize darolutamide in your patients, definitely it is the standard of the care, and you can do so. Also, if we see there is some data for OS update, which came as a subsequent analysis, and sensitivity analysis also accounting for subsequent therapy. So this is the post hoc sensitivity analysis, patients who received darolutamide versus placebo as a part of the trial. If you see in post hoc sensitivity analysis, initiation of subsequent systemic antineoplastic treatment was counted as an event in censored patients who entered follow-up. In this study, you can clearly see the primary overall survival analysis. In the analysis, we have seen that post hoc sensitivity analysis counting use of subsequent therapy as an event, and you can see the difference. Again, if the subsequent treatment is used as a censor event, again, darolutamide is becoming important. That is very clear. So just to highlight, the most patients in the placebo receive subsequent life-prolonging therapies compared with the darolutamide. That is bound to happen because the patients will have a shorter time to progression, and incidence of adverse effects were definitely important. And also longer hospital stay and favorable tolerability. It is when the drug is well tolerated, the toxicity profile is good. We know that the hospital stay and everything will be reduced and not very much different from the placebo arm. So it's very simple and important that the patients who are receiving darolutamide addition are not having decreased quality of life, poorer, more hospitalization, and ability to complete 6 cycles of docetaxel. There is also a systematic review that indirect treatment comparisons are whether they are important. So there are some more data coming up, and I think This is trials will pave the more data, but these have their own limitations. So the message is loud and clear. Wherever feasible, patient is high volume disease, definitely incorporate darolutamide along with docetaxel in the practice. We already know about the NMCRPC data, and in our experience, the drug is so well tolerated and has least adverse effects from the point of view of an ARPI. Among the ARPI, the least adverse effect is by darolutamide. That is what has been my experience also. Thank you.